Started now for the next session. Want to thank everybody, and we have more people are coming in now for the afternoon session. It's my pleasure to introduce Dr. Edy Soffer from USC, who's going to talk about endoscopic and surgical therapies for gastroparesis. So, Edy, thanks.
Thank you very much. Good afternoon. See? All right. So, gastroparesis is a syndrome characterized by delayed gastric emptying and upper GI symptoms that suggest but are not associated with obstructive lesions. Diabetic, idiopathic, and post-surgical are the primary etiologies of gastroparesis. Gastroparesis results in substantial morbidity and healthcare cost burden, and there is a limited menu of pharmacological agents and in general a treatment for this condition, which drive the search for alternative intervention. So before we talk about that, just a couple of minutes about physiology. So for a healthy stomach to do its job, it needs a healthy extrinsic innervation, primarily vagus, as well as intrinsic nerves built in within the wall of the stomach. It needs a normal accommodation, which depends on intrinsic inhibitory neurotransmitters. It needs a normal electrical activity, which depends on a network of pacemaker cells that start in the distal body and all the way down, and which then in turn drive the normal mechanical activity that depends on a healthy muscle, of course. And so at the end of a meal, let's say the lunch that we just had, that stomach goes into overdrive, and the antrum will contract and contract until everything is reduced to tiny particles of a few millimeters that come out of the pylorus. And that emptying, depending on the meal, how much fat, may take hours. That's a normal, healthy stomach. In gastroparesis, some or most of these mechanisms are impaired, which can contribute to symptom and results in delayed gastric emptying. So the intervention that were devised over the years basically address the stomach in different ways. So you can remove part of it, or all of it, and so there's no issue with emptying because there's no more stomach, and you hope also that the symptoms will improve. You can deliver electrical stimulation in the hope of improving symptoms. And you can address the pylorus. Why the pylorus? Because there are some old data and some newer data that show that in patients with gastroparesis, primarily diabetic, the pylorus is spastic. So it will presumably prevent adequate emptying. So the interventions we're talking about are pyloroplasty or gastric resection. This is the surgical part. Gastric electrical stimulation, also surgical, but it's non-ablative. And then the endoscopic, Botox injection, and gastric peroral endoscopic myotomy, which is GPOM. And so we looked at the data and reviewed those various articles that were involved, and for the sake of having a more homogeneous population, we concentrated only on the medical etiology of gastroparesis. We avoided those that were primarily post-surgical. So we excluded those that were very small, 5, 6 patients in a series, post-surgical etiology as the primary component, lack of standardized assessment of symptoms. Some papers simply comment on, well, the patient mentioned that they're better, and this is just not adequate enough to include. No etiology provided, or repetitive studies by same authors. And what I want to do now is basically go and review every one of these interventions. So look at pyloroplasty. The upper panel are the various descriptors. I stands for idiopathic, D for diabetic, and PS for post-surgical. And you look at the follow-up, anywhere from 1 month to 1 year. The outcome assessment varied. Some people use a severity score, other GCSI. For gastric emptying, they use a T-half. This is a less acceptable way of assessment, gastric emptying nowadays, or retention of 4 hours. And then as the results on the next, the penultimate panel, change from baseline. All of them basically showed a significant improvement in symptoms and a significant improvement in gastric emptying. And the adverse events, minor. So pretty safe intervention. To the gastric resection, 3 studies that fulfilled what we're looking for. Median follow-up here is from 6 months to 2 years. The assessment varied from symptom score, GI quality of life, to GCSI. Again, change from baseline, they all did well. They all improved significantly. Safety profile, good for the last 2 studies. The first studies had some issue with leaks and reoperation in about 20% of the patients. What about gastric electrical stimulation? So this is a high-frequency system. It's called Entera Biometronic, and it's available for clinical use, and that's the only system that is available for clinical use. And on the right, you see the way it's implanted. Basically, you put 2 electrodes in the anterior part of the distal body, and then you connect the lead to the stimulator, which is then put in a small subcutaneous pocket. And that's it. Pretty simple procedure. There are several open-label trials, all reported good efficacy in control of symptoms, which I will not review. There are 4 more robust studies, 1 small, short-term randomized study that showed efficacy, 2 control crossover studies that gave mixed results, 1 randomized double-blind crossover study, which I want to review. This was a robust, multi-center European study published within less than a year ago. So they included patients with chronic vomiting and or nausea, more than 1 year, severe, that is, severe enough to affect general condition, weight, and diet. They chose 2 primary endpoints, improvement in GI quality of life and in vomiting frequency. And in the middle there, you see the flow chart. Enrollment took about 4 months. Then implanted the patient, waited a month, and then randomized, either on or off, the device on or the device is off for 4 months, and then every patient crossed to the opposite. Those that were on moved on to off, and the off moved on to on for 4 more months, okay? And here are the results. When you look at the GI quality of life, one of the primary endpoint, no difference between the 2 on and off, and no difference between baseline. When you look at gastric emptying, there was no effect of gastric emptying. That should not be surprising because the pulse that is being used for electrical stimulation doesn't really pace the stomach, okay? And then you look at the second primary endpoint, which is vomiting frequency. And on the left-hand side, you see the mode, which is on and off. In every one of those, there are 2 lines, one for more severe presentation, more than 1 vomiting per month, less than 1 vomiting per month. And on the rubric as on the right, you see the results. So if you take the intention to treat, you see that during the on period, 50% of the patient did not do better. And during the off period, 64% did not do better. You want to flip it, you could say 50 did better and 35% did better during the off, for a delta of about 15%. That is a gain of about 15%. Okay? Same result with the diabetic, same result with the idiopathic. That will be relevant when we talk about placebo effect of interventions. What about Botox? So the idea behind Botox is, the pyloric is spastic. Botox result in smooth muscle relaxation, albeit only short, a number of months and up perhaps to a year at most. And if we'll do that, maybe the pylorus will open up and it will enhance gastric emptying and symptoms. So we look at the open label studies. They found that male gender and reduced pyloric distensibility by endoflip before intervention predicted response. I will not present these studies. I'll present only two, which are the better ones because they're controlled. And the first one, 20 patients, prospective, though non-randomized, follow-up 1 month. The assessment was by dyspepsia questionnaire. And when they looked at the end of the month, change from baseline, symptoms got significantly better, gastric emptying got better. Now the same group, and that's on the bottom, a year later, now did a study which is randomized. And they did a crossover, something similar like the one on electrostimulation. So you go for 1 month with a saline and then Botox, or start with Botox and go to saline. And they're assessed by GCSI and breath test. And here there was no improvement compared to baseline and no difference between saline and Botox. Okay. And now to the last kid on the block, the gastric peroral endoscopic myotomy, GPOIM. 8 studies, open label and controlled, mostly retrospective. Median follow-up about 10 months. Participant median of 33 subjects, 13 to 100. Good safety profile. Inconsistent effect on gastric emptying. And in a recent meta-analysis, success rate 82%. The most recent study that was published in March, actually is already available in March, is a prospective study, multi-center with less favorable results, and this is the one I want to present because this is the most robust of all the ones published so far. So this is prospective, multi-center, patients refractory to standard medical therapy with documented delayed gastric emptying. There were 33 idiopathic, 19 diabetic, post-surgical, 19. The primary endpoint, clinical success defined by metrics of the GCSI. GCSI, for those who don't know, is a standard questionnaire that assesses a number of symptoms related to the upper GI tract, and is a standard one and common one used in gastroparesis trials. Assessment of symptom, 1, 3, 6, and 12 months. They did the gastric emptying before and 3 months after the procedure in about 66% of the subjects. So what did it show? Clinical response at 12 months, and at that time they were left with 75 patients, was 56%. And there was no difference between the subgroups, diabetic versus idiopathic. There was a moderate improvement in subclasses of GCSI. Gastric emptying improved in about 60%, normalized in about 50%. The improvement in gastric retention was moderately correlated with reduction in GCSI. In other words, the improvement in gastric emptying is correlated moderately with improvement in symptoms following the procedure. Predictor of success at 12 months, a baseline GCSI score greater than 2.6, in other words, a more severe disease predicted success. A more severe gastric emptying also predicted success. And clinical response at 1 month predicted that they will do better as time goes by. Mild adverse events in 5 patients. So where do we stand? Most studies are retrospective, small number of subjects, markedly heterogeneous. Fewer randomized, placebo-controlled, double-blind study. And the good results that are observed in the open-label studies are not reproduced when you do a more rigorous study. And why is that? There's some good reasons for that. When you look at patients which have gastroparesis symptoms, with and without gastric emptying, they have comparable clinical presentation. You may not be able to tell the difference between a patient that has severe symptoms from that has severe symptom and delayed gastric emptying, meaning gastric emptying may not be the only driver. There's vague, controversial correlation between gastric emptying and symptoms. And there's a high rate of placebo effect in pharmacological studies of gastroparesis, almost 40% placebo effect. And the study that you show, both the Botox and the electrical stimulation, give you an idea how high can the placebo effect be. So I think there's a need for rigorous studies to determine predictors of success and the best choice of patients that can benefit from gastric intervention for gastroparesis. This is particularly the case when it comes to endoscopic intervention, because these interventions, no matter what you do lend themselves to the kind of rigorous studies, namely double-blind, sham control, which you cannot do for ethical reasons if you operate on a patient. So we need those ones so we can know how good are these interventions and who is the patient that can best benefit. Thank you very much.
Great. Thanks, Edy. That was fantastic, and I appreciate the rigorous look at the data, because this is a field that we need to think carefully about. So thank you. I'm going to be giving the next talk, and this will be